So, so what is the difference here? Initially, you make a flap and zap. You need a machine to flap or a blade to make a flap, and then you take it to the other machine and zap with the excimer. When they realized you can make flap with two modalities, you can use a blade or you can use a laser, which was femto laser, which was 10 to the power minus 15. Then they realized that if you compare the statistics, the blade are not faring as good versus the laser. So they saw these cases and realized that the standard deviation of the shift of the thickness is about plus minus 20. That was the maximum. So it was very precise cut. So I think people got idea, if you can cut it so well with the femto, why can't you get away with the excimer, have one machine only? So you can have cut two lenticules, make the cornea the power which you want to give it, and you take the lenticule out. And that's how this thing has started. So because the effect of on the cornea of the femto done because of the femto LASIK surgeries, they have come out with conclusion. So I think that's well taken. Okay, so two important things. The strength of the cornea is everybody talking about. Ectasia has nothing to do with the strength. Of course, if the cornea goes thinner, more chance of ectasia, but you can have it with the -2 LASIK also, and you can have it -1.5 PRK also. So there are some factors which nobody knows why they're happening. So whatever studies I'm quoting is in favor of the SMILE, because what they found out that if you see in these patients, there was 7 times more strength in the cases of SMILE versus the LASIK for the same power. And since you're not cutting the nerves all 360, your dry eye also is better. So SMILE is better for the surface things, for the corneal denervation and the dry eye, plus it gives the more strength. And the strength was measured on Corvus and ORA, and these both systems are working, but they're not foolproof. There's still patients in which you can't pick them up well, but that's what is the gold standard as of now. What comes in the future, we don't know. So we can say it's better, and we just have to wait and watch and what happens to these patients. So what happens is you basically create a flap and take the lenticle out. You have to be precise, docking of the cone, and I think I'll show you a video and that'll explain everything. Okay, so you always have to cut the posterior flap first, because if you cut the anterior first, the light is not going to go beyond that anterior flap, which is opaque now because of the bubble, and posterior will not cut. So cut from the back, come anteriorly. So the first, once you've done the docking, that's a center fixating light for the patient. It cuts from outside in, that's the posterior wave going. And then the anterior wave, which is about a 0.5 millimeter bigger, 1 millimeter bigger, and it starts with the center out. This is not an edited one, so this is giving you a complete. So you just see this is the actual time taken for the surgery. So I'm not going to reduce the speed, increase the speed. So that's the second one. It's gone across, and you got an incision at the side here, and you're good. So that's what the machine has done. It has created the bubbles inside, and it created the layers. Now what you have to do is you just have to separate these layers using the skills, and that's where the skill is required. If you've done 5 patients with the proper splitting of the layers, you're as good as anybody else who done 50. But of course, the experience counts. The more you do, the faster you can go. So you create a pocket now, open up anterior. These are the layers which are already cut. Then you go with a separator. You go to the anterior first, go up in the middle. I think I should run fast. This is rather, okay. So once you go here, you have separated the anterior one, and you separate it all around. The cornea looks very bad right now because all these bubbles are there. The next morning, all these bubbles are going to be gone, actually, and the cornea are going to be crystal clear. So we have seen the patient which have come up for follow-up after 1 year, LASIK versus this one. LASIK still has some interface issues here and there, but the SMILE interfaces are absolutely clean. They're clean. So once you've taken out both, it's cut from all around. You just hold it and pull it out. And that's the lenticle gone out, and your procedure is done. To wash or not to wash, again, some people wash it. I wash inside, so I wash all the debris which are there, and that's about it, and that procedure is over. So it takes much less time than the LASIK because you're doing on the one procedure. Now this patient was done on LASIK. When you cut the cornea 360, you have little irritation. So this one is smiling more, so this was a SMILE procedure, fine. All right, so what are the shortcomings of the SMILE? Till October 2018, the FDA had not approved it for the toric one. So -1, 8.25 spherical equivalent, or -0.5 cylinder was what the FDA had allowed till October. In October, they come out last year that you can go till -3 to 3 diopter of the astigmatism, and about -10 spherical equivalent, which is pretty high. So the cylinder has been incorporated, and I think people are using cylinder. Dr. Grewal and all were using cylinder here earlier also, but now you can say FDA says so. So it is stamped by the big papa there. All right, so ectasia can happen with this also. You can't tell patient the ectasia is thrown out of the window. No, please, whenever you're counseling this patient, you have to put this into right perspective. You tell them this procedure is All the complication of LASIK can happen in this one. All the pre-op workups of LASIK holds true for this. So I'm not going to go for the pre-op because whatever Sataj said is holding true for this surgery as well. So if you have issues of ectasia and all, and if you have keratoconus, this is a big no. So all the indications as of them are here, except if you want to keep the strength, you have the borderline case, you can still go away with the smile as compared to the LASIK. Okay, so what are the complications? Of course, you'll have complications. Since these are the soft suctions, these suctions are not very firm, like the femto, the good old surgeries in which you have good large, when you're using Hansatom and all those, you're having 60 millimeter pressure. So these pressures are low. So the patient, if it moves, you can lose the suction. So suction loss can be there. There could be areas where the laser does not fire because the cornea was dry, so the laser didn't fire, or there was some debris which you didn't clean up. So that area is going to be sticking. You'll have area cut around, but that islands, those islands called black spots will be there. So when you're splitting them, you might get stuck there. But if you're if you're a good surgeon, you can actually manage those ones. But it can be avoided totally. You can have bubble layer, which is seen for first few days and then it goes away. Epithelial defects can happen in these ones, but that's a short thing, and on the surface can go away. You can identify wrong planes in the beginning. It happens with everybody. We also burnt our fingers. You're going into the posterior one first. So once you split the posterior, the lenticule is stuck to the anterior part, which is about 120 micron, doesn't have a strength. So you can't push it up. So that's why you should do the anterior dissection first, and then you can push it down towards the stroma, which is still about 400 microns down there. So you have the strength, you can actually push it and poke and you do whatever you want. So that's why the anterior has to be split first. So that can happen. You can have a tear of the capsule, you can have the tear of the, caps, and the incision can also get torn. So you start with the big incision, 3 millimeter, then come to 2 millimeter, because most of the time in the beginners I've seen, the incision does get big. You can go to 3 also. Dr. Mahipal, I think, usually uses 3. It depends on what is your surgical acumen in that one. And you can have post-op epithelial ingrowth. Is still possible here, so that's why you keep eye on that. You can have inflammation to some extent. It was happening earlier when we were using higher energy, but now with the energy modulated, the interface things have reduced and things are passed. So day one, we have 6-eye vision in about 90% of patients. Initial few patients, which we did about a month, the first 1 month, we were also skeptical. We were not going dissections very well. We had more reactions, and we are using high energy. Now we got energy very low, so the damages to the stroma is also less. Okay, so I'll just go. So you can have lenticle tear. This video looks bad, but at the end, the patient has 6/6 vision on by the end of 1 week. So half the lenticle has come out, half is not. You see this one? This is not a complete lenticle. The one which you saw in the beginning was a complete lenticle. So go ahead again and hold it. Now what is happening? You see the patient is not cooperative. So best in this is to hold the eye and do it. And sometimes it's the anxiety of the patient which causes. You can see the incision has also gone a little bigger, and the lenticle has come in 3 pieces, but it's come totally now. And then you can check it out on the surface. So this can happen, so don't get disheartened by that. You can have suction loss, because I told you the suction can be lost. So you put in a thing, it started working. Okay, it's working so well. If what you notice now is, you have a pointer here? Yeah. So you see the conjunctiva started coming in. Now this is time when you should actually stop and dock it again. But for the beginners, you think it's going to get away. So it's still going on, and the conjunctiva is coming in, the machine has stopped working, and suddenly you realize that this is gone. Now see, it's gone. The patient has moved it. So you have set protocols depending on how much percentage you cut on the in the flap, and you can again use the same PI and go ahead with the surgery. So that protocol I'm not discussing, but you have protocols in place. You can take care of that. This one we docked it again, and you see we cut it again, and we have 3 layers, but we took out the layer in the middle, and the patient was again okay, fine. Now you can have the suction at the end of the surgery also when everything is done. I think my time is less, so I can skip this video. Okay. Now that is what is a black spot, right? So when you're going inside, you're splitting. This will split very easily because there's bubbles all around splitting 2 layers of cornea, whereas this is going to be a little dicey. So for the beginners, you have this one. You've got to be a little, you have to take a little sharper instrument than a very blunt one, and you can just actually go through it, and it's possible to do it. So far, I have done 506 cases. RP Center has done more than this. I think maybe the double number, because Dr. Tityal's unit does it and I do it. So the minimum I used was a 1.75 diopter, and -9 was the maximum I used. I was following the FDA, and I was using up till 1.25 cylinder, but now I started using more. So last week we did about -2 patients, and they were good. Okay, in the first few patients, the vision was hanging around 6.9, 6.12 for the first 2-3 days, but it came down to 6.6 eventually. And all my 1-year follow-up patients, none of the patient is less than 6/6. So that's a good sign. And longest follow-up I have is about 12 months in these patients. And I think we can overcome these difficulties like the suction loss and all. So you have to have patient counseling. In fact, I give patients Alprax before, a night before, so that they're more calm, especially for this one. Whereas most of the patients are doing good. And one patient which had the suction loss, we did the Dishler's technique and the patient's 6-5 vision. And that doesn't mean that if you have a smile, you throw your excimer away. So sometimes you get stuck with the excimer, with the LASIK, you have to convert, the smile you have to convert into a LASIK procedure. So you still will have to give a machine. I hope, Dr. Grewal, you haven't thrown your machine away yet. I think you never know when you need it, but it is a good thing to keep it back. You can't promise them 100%, but because 100% is not possible in anything. So software don't have a 1 millimeter. I want 1 millimeter incision on the side, so that if the main incision somehow is you're not comfortable, you can make one opening from the side and do it. I call this a bimanual technique, two incision technique, which I follow. And with that, you can actually cover all the 360-degree easily. The software is a little iffy because in case there's a fiber or something, you can't actually see it on the table. You have to go to the slit lamp and come back in case it's there. And optics could have been improved on this one. Foot control on the microscope is not there, but in RP Center, they've given us foot control. So you can ask them to get your foot control so that the movement of the machine is with the hand. So if you're doing a procedure and your hand has to be left and you have to rotate the knob, it doesn't work well. So you can have a foot control, so that way both the hands are free. And you can add an OCT there. In case you have a lenticule which is left, so you can always see it on the OCT if it's a small lenticule. Small lenticule in the periphery can be left aside also, but if it's a big one, OCT can help you, which is not there on the machine, but I think we can ask these guys to add on to that. And so to conclude, SMILE is safe. There was no loss of vision in any of these patients. And it was predictable because there was no regression in any of these patients. And cases of low to high to moderate myopia. Thank you.